This segment of Delmarva Life is brought to you by Peninsula Regional Medical Center.
You know, when something is wrong with your car, a mechanic can open up the hood or crawl under the car to see what's wrong. When something is wrong inside your body, say inside your lungs, it's not as simple to open up your chest to get a look inside.
That's a whole other issue, but an interventional pulmonologist can get a good look inside your lungs. The problem is there are only 250 of them in the country. And guess what? We have one with us today. This is Dr. Yash Sangwan. He is the Director of Interventional Pulmonology at Peninsula Regional Medical Center. Doctor, thank you so much for joining us today.
Yeah, it's nice to meet you.
So can I ask you a really basic question before we get started? What is an interventional pulmonologist?
So interventional pulmonology, it is the latest branch in medicine to have its own fellowship training and also its own board certification. Okay. So we are lung doctors who have advanced surgical training. We can do things that regular lung doctors can't, and we can do things that CT surgeons should not, because they are doing bigger and more complicated, surgeries.
Yeah.
So we are right in between. Half of us are part of pulmonary department and half of us are part of CT surgery department.
So as Jimmy had mentioned, there's only 250 in the country, and we have, what, 2 here on Delmarva?
We have 2 here, yes.
Yeah, why is that?
So what happened is that when I first did my residency, there were about 8 of us coming, interventional pulmonologists being trained every year. Now there are around 40. So when I started 10 years ago, it was a very rare thing. I wanted to sort of make it my life's work to prove to myself that in order to open an interventional pulmonary program, you don't have to be linked to a big university. Okay, so we are maybe the second program in the United States where I'm operating in a community setting, which is also not linked to any big university hospital. Dr. Robert Chasse had already started the work here when I joined, but the reason I joined him is to make sure that we give IP to the peninsula and just keep bringing in the latest technology to the people here.
So what kind of things do you do? What kind of things do you see? What kind of things do you work on?
So it is like this. If you have a flat tire, okay, one of the jobs that doctors have is why did the tire get flat, so that we can prevent it.
Right.
But ultimately, the patient is suffering from symptoms, and those symptoms have to be treated. There are no lung diseases that are untouched by interventional pulmonary. Either we go in to diagnose stuff that has not been diagnosed, or we go in to fix stuff. Okay, so if you have fluid around your lungs, I might not know right from the beginning why there is a fluid, but I can fix you today and I can send you home today. Okay. If you have COPD and asthma, I can go inside and do mini surgery that can take away the bad parts of your lung or prevent your lung from getting an asthma attack. And while we are also, as pulmonologists, because after all I'm also a lung doctor, I'm working out why I'm treating you first, because you are not here because you have a diagnosis. You are here because you're short of breath.
And one of the things you can do is get down inside and look at the lungs, and you actually have a picture here. What are we looking at here?
So this is us doing an awake fluoroscopy. One of the latest techniques. Before, only surgeons used to do it. If the patient has anything around their lungs, fluid or a lung collapse, and we want to find out why, this is the best technique to go in, not only just to look at the lungs from between the ribs and see what's wrong, but also because it fixes it in the same go.
So this is a normal lung?
Yes, this is a normal lung that I have deliberately collapsed because I need space to work. And on the top, you are looking at normal ribs. This is what a healthy mucosa looks like.
But this one, on the other hand, is one that is cancerous?
Yes. So the patient was having fluid around the lungs. The only technique we had until now was to drain that fluid and send it for testing, which is only 50% of the time it will actually tell you what's going on. Here in this case, on the same day, the fluid was negative for cancer, but we went inside with a small camera, patient being awake, just pain control, talking to us, and we found cancer. So it is a technique which is 98% certain. If you have any problem in your lung which is causing this effusion, and we can't find out using normal techniques, I can go in, we can take a look and biopsy it.
Okay, we could spend the rest of the afternoon talking to you because this is fascinating. We are out of time, but can you quickly show us some pictures of how many instruments you use at one time?
Absolutely. So if we go to the picture where I am actually going after a small lung spot.
Right.
Okay. So somebody tells you that you have a lung spot and it can be cancer. That is a patient that is losing sleep. Okay. So I want to make sure that we get the diagnosis. One of the things is a GPS instrument. Okay, so we have an electromagnetic field over the patient, and we have the patient's CT scan in a computer, and the computer tells me to go left, to go right, go forward, go backward with the instrument.
Oh my goodness.
So that I can reach there. Now the second thing is that you also want a drone, which is our X-ray, to make sure that I'm going to the right part of the lung. The last thing is visual confirmation, because if your GPS says turn left and you are like, there is no left.
It's fascinating.
Okay, so that is the ultrasound picture where we actually see that 1 centimeter spot, so that we have 3 ways of going in there and taking biopsies so that you get the answer you want.
We need to have you back so we
Yeah,
can
no
talk more
kidding.
about this. Thank you
Thank you
so
so
much
much.
for being
Thank
here
you.
Wow,
and
thank you.
talking
Just
about
for us.
all
Yes.
of this.